Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
It is estimated that 1 in 8 women will be diagnosed with breast cancer in their lifetime. However, your risk is higher if you have a family history of breast cancer or inherited mutations in your BRCA1 or BRCA2 genes. In fact, up to 65% of women with a BRCA1 mutation will develop breast cancer before age 70. Hi, I'm Dr. Roy Jensen, Director of the University of Kansas Cancer Center. Dr. Carol Fabian, founder of the Cancer Center's Breast Cancer Prevention Center, is with me this morning to discuss research efforts focused on helping women at high risk for breast cancer. First of all, could you tell us why breast cancer prevention is the primary focus for your research?
Absolutely. Well, only 20% of women currently diagnosed with breast cancer are ever going to die from it. This is a tremendous advance over the way things were 30 or 40 years ago. However, I still believe that prevention is so important for a variety of reasons. One, if you prevent cancer, you do not have to deal with the long-term side effects of cancer treatment. You don't have to deal with the terrible financial burden that breast cancer treatment can cause. And you don't have to deal with the emotional ramifications of change in your lifestyle, concerns about fertility, just the emotional trauma that you and your family go through during cancer treatment.
Mm-hmm. So if I've got this right, I believe you founded the Breast Cancer Prevention Center over 30 years ago.
Yes.
And how has the research from that clinic helped shape the way we treat high-risk women today?
Well, 30 years ago, we were just beginning to understand how to even calculate risk for breast cancer. We didn't have genetic testing, and all we had was a new, very simplistic model to calculate the risk developed by Mitch Gale at the NCI, called the Gale model. So anybody that had a Gale model calculation that said their risk was more than that of the average 60-year-old was eligible to get prevention medicine. And this prevention medicine was actually a drug that we used to treat breast cancer called tamoxifen. And even though tamoxifen is a lot better than chemotherapy, it still had a lot of side effects, particularly menopausal symptoms, increased risk of blood clots, and even an increased risk of uterine cancer. So women looked at this Gale model prediction and they said, yeah, I don't really know how accurate that is. And this drug has all these side effects and I feel fine. So guess what? Less than 5% of women who didn't have some other indicator that they were at short-term high risk refused to take the prevention medicine, even though it reduced risk for breast cancer by 50% or more.
Mm-hmm.
So we kind of thought there's really got to be a better way. We knew from your work at Vanderbilt and Dr. Page that women who had abnormal looking cells but not cancer cells in their breast tissue had a much higher short-term risk for breast cancer. But most women with a family history had never had a breast biopsy. So we used a new technique that we developed called random fine needle aspiration to just sample the breast tissue in a non-invasive, really not very uncomfortable manner. We did that with 500 women that had a family history or other risk factors for breast cancer and followed them over 5 years. And what we found is that changes in the tissue, including these atypical cells, predicted short-term risk for breast cancer. We found, and other investigators found as well, that women who were found to have these changes in breast tissue were much more willing to take these drugs or try new treatments to help prevent breast cancer. So we feel that our research that started over 30 years ago in terms of developing markers of risk for breast cancer development has really helped the whole field of prevention take off.
Mm-hmm. So one of the things we want to talk about this morning is one of your recent studies that has identified a new use for a drug that's been pretty commonly used to treat osteoporosis for quite some time. Could you tell us more about that?
I'd love to. As you know, one of the reasons that women who don't have breast cancer don't want to take tamoxifen or some of the other drugs for cancer prevention is that these medicines cause hot flashes. Mm-hmm. Women who don't have hot flashes don't want them. Women who already have hot flashes don't want to make them worse. So this new drug that you referred to was actually approved by the FDA in 2013. It's called Duavee. Duavee is a combination of an anti-estrogen, a drug much like tamoxifen called basidoxifene, which is anti-estrogenic in the breast tissue, in other words, helps prevent cancer in the breast tissue, but actually is estrogenic in the bone. In other words, helps keep the bone from demineralizing and developing osteoporosis. So basidoxifene was combined with a low dose of conjugated estrogen, and I'll explain what conjugated estrogen is in a minute. The conjugated estrogen was to help with hot flashes, because if you just gave basidoxifene by itself, it would probably cause hot flashes. So basidoxifene and conjugated estrogen were combined in one pill to form Duavee. The clinical trials found that it relieved hot flashes completely in as little as 2 weeks, and was successful in preventing osteoporosis. So again, it was approved by the FDA for those two indications. Well, we looked at some animal model data with the drug, both in monkeys and in mice, and we thought this may be a very good drug for cancer prevention. It seems to slow the growth rate in normal breast tissue and prevent the outgrowth of clinically inapparent tumors in mice. So 2 years ago, with support from the Breast Cancer Research Foundation and the Cancer Center, we started a pilot trial in a number of women who were actually having hot flashes and wanted relief from them, but they were also at high risk for breast cancer. What we found is that 6 months of treatment of the Duavee dramatically reduced growth or proliferation in the breast tissue. It also reduced mammographic breast density, which is another risk factor for breast cancer. And it reduced several factors in the blood that are also risk biomarkers for breast cancer. And that includes progesterone, testosterone, and a growth factor called insulin-like growth factor. So based on these very exciting results and the fact that these women had complete relief of their hot flashes and other menopause symptoms, again within 2 weeks, we're proposing a much wider trial with a number of cancer centers in the United States, this time with the placebo control. We also are looking at how this drug affects expression of multiple genes within the breast tissue.
So in that study, is the company providing a drug, or is the study going to have to pay for the drug?
We asked the company to provide drug for the pilot, and they did. They did not provide any funding. In the new study that we're proposing, just to free us from any bias from the company, we will actually be buying the drug, which will be encapsulated by a third-party company, as well as placebo will be encapsulated by that company as well.
Okay. So your efforts over the last few years have spanned quite a spectrum. Could you tell us a little bit about, for instance, your weight loss and exercise studies?
So when women, particularly moderate risk women, think about cancer prevention, again, they don't want to take a drug that is going to cause a lot of side effects. And most women would rather do an intervention either with a natural product, like omega-3 fatty acids or lignans, things that they associate with health. Or if they're overweight or obese, they would rather do a diet and exercise intervention rather than take a pharmaceutical product.
Mm-hmm.
So we became very interested in how do we get women to do diet and exercise. Furthermore, how much is enough? That's something we really don't know.
Mm-hmm.
How much weight loss does it really take? Are we really looking at the right thing? Is weight loss really the key, or should we really be looking at reductions in body fat, or maybe a particular type of body fat? We're beginning to learn that the deep belly fat around the intestines and the liver, even though in average weight people, there's only a very small amount of this, is responsible for a lot of the hormones and cytokines and various other evil humors that really increases the risk not only for breast cancer, but for colon cancer and possibly prostate cancer as well.
Mm-hmm.
So, to make a long story short, both with NCI funding, with funding from the Cancer Center and other sources, we have been looking for ways to help both high-risk women and breast cancer survivors lose weight and keep the weight off. And what does that do, again, to risk biomarkers for either breast cancer development or breast cancer reoccurrence? So the long and short of it is when you have a successful intervention, which is usually a portion-controlled diet, like healthy meals or Weight Watchers or something that you would buy at the store, have a group behavioral intervention where you bring women together either in person or by phone. They form their own support group, and you give them information and help them along with the process at least once a week. And particularly for older, very obese breast cancer survivors, that's not enough. You really need to help them and support them with a personal trainer at least part of the time to help them get going as far as the exercise. So what we found is, one, it takes about a 10% weight loss to reliably improve risk biomarkers for breast cancer recurrence. Two, with a personal trainer twice a week, plus providing women with a safe place to exercise, like a regional Y, that even very sedentary women can get up to an amazing amount of exercise per week, over 200 minutes a week. And the combination of weight loss and that exercise dramatically reduces the belly fat, the visceral adipose. And even though maybe you only lose 10% of your body weight, we've shown that with diet and exercise, you can lose about 30% of your visceral fat over a 6-month period of time. Furthermore, you don't need to keep the trainer forever and ever. The trainer for about 12 weeks, it seems to be enough to do the job to get the women from not moving at all to doing moderate or vigorous exercise 200 or more minutes a week.
You got to turn it into a habit.
Yes, absolutely.
Yeah. So if you're just joining us, we're here with Dr. Carol Fabian talking about breast cancer prevention research. Remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. Could you tell us about some of the emerging research in breast cancer field and breast cancer prevention that you're most excited about?
Well, probably what I'm most excited about is this whole idea of repurposing old drugs, old inexpensive drugs that might be used for some women with breast cancer, or excuse me, for some women at high risk for breast cancer, One of them is metformin, and that's an ongoing trial that we actually participate in. The other thing is taking an old drug like tamoxifen, which is very inexpensive and we know works, and see if we can get by with a lower dose that isn't going to cause all the side effects. So a clinical trial that was performed in Italy and published earlier this year shows that low-dose tamoxifen in people with precancerous breast disease actually could reduce risk pretty readily. But the questions remain, well, does that hold for everybody? Does that work for premenopausal women? Does that work for postmenopausal women? Does that work for obese women? Is a long-term follow-up of the Women's Health Initiative. Just to remind everybody, the Women's Health Initiative looked at randomizing predominantly average risk women to conjugated estrogen alone, or placebo if they had no uterus, or conjugated estrogen plus progestin if they did have a uterus. Periodically, they keep analyzing the results of that trial. Very early on, it was obvious that conjugated estrogen plus a progestin in women that did have a uterus increased the risk of breast cancer. Not by a huge amount, but taking it for 5 years increased your risk of breast cancer by a relative amount of about 25%. So if your risk per year was 1%, your risk per year then would become 1.25%.
Right.
It's kind of like the same risk as drinking about 10 drinks a week. So, but the other sister trial, conjugated estrogen alone, didn't cause increased risk for breast cancer. In fact, there was a hint that it might actually reduce risk for breast cancer. How can that be?
That aspect of the study was not widely promoted.
No, it isn't. But this aspect is holding up with time. And in fact, there is a recent analysis at about, 18 years or something of follow-up. And conjugated estrogen, particularly in the 50 to 59-year-old age group, continues to significantly reduce risk for breast cancer and improve all-cause mortality, particularly if you're in the 50 to 60-ish year-old age group. How can that be? Well, conjugated estrogen is not like estradiol. It is not a single substance. It comes from horse urine, and it has at least 50 different compounds or chemicals in it, some of which probably are cancer preventative. In other words, they're like a SERM, like tamoxifen. There are other theories about how this works, but then that brings us back to the Duavee situation. Even though gynecologists use Duavee for women with hot flashes and osteoporosis, this is mostly average risk women. Because it has estrogen in it, they're afraid for high risk women who have an increased risk of developing breast cancer anyway. And I just don't think it's widely appreciated that conjugated estrogen by itself is a safe drug.
Yeah, and I think, the other thing about the original study was that a lot of those women were older and had long passed menopause when they were started on the drugs. And
You're absolutely correct.
That's a totally different population.
Yes, than the women who want to take it for hot flashes.
That's right.
You're absolutely correct. The average age for the Women's Health Initiative to start was 63.
Right.
And many of these women had actually been on hormone replacement therapy before.
Right.
So it was really important to break this all down by age group, by weight, by other things that could cause a problem. Because oral estrogen, particularly after the age of 60 to 65, can cause the liver to put out more blood clotting proteins.
Right.
So the problem is if you're an older person and you're taking oral estrogen, you could have an increased risk of heart attack or stroke. So you don't want to be doing that.
Right.
If you need estrogen and you're older, you want to be taking it by a patch or a cream or something like that.
Right.
So anyway, we're going to hear more of an update about the Women's Health Initiative. But you asked about other things that are exciting on the forefront and practical. I think that a lot of the work that's being done to help treat DCIS, HER2-positive DCIS with vaccines is very exciting. In other words, if we have precancerous breast disease and it's expressing some of these proteins on the surface, can we make a vaccine to treat that versus having to do mastectomy or lumpectomy and radiation? So I think all these things are very exciting.
So I'd like to come back to a point, a very important point that you made earlier, just to emphasize something, and that is the use of kind of old drugs or repurposing drugs in prevention, and why that's so important. I think one of the things that a lot of people don't appreciate is that a big part of the reticence in pharmaceutical companies to even engaging in prevention is that when you start putting millions of people on a drug that are at relatively low risk, then the side effects become very, very important.
Yes, bad things are going to happen to a very small percentage.
Yes, and one of the beauties of being able to utilize a drug that's been around for a long time is we have a much better understanding of the side effect profile and whether or not it's worth the potential risk in terms of whether or not it can prevent cancer. And so I think that's a great strategy because you've, to some extent, you've de-risked the issue in terms of what the side effect profile is, or you understand it. And so then you have good data to really figure out if this is going to be a worthwhile intervention. So,
and there's many drugs that we really should be looking at. And usually these old drugs are inexpensive, they're generic.
Long off patent.
Long off patent, so people aren't trying to pay or aren't forced to pay $300 a month for a prevention medicine.
So one question, which I assume you get quite a bit, is what advice do you have for a woman who has just found out that she's at increased risk for developing breast cancer?
That is a great question, and it has multiple facets. The first thing I would advise her to do is try to find a high-risk clinic, like the one that we have here, and schedule a consultation. The first thing that she needs to understand is what is her level of risk? Is she at moderate risk? And if so, might be benefited more by healthy behaviors than anything else. Is she at high risk, like people with precancerous breast disease who've just had a biopsy showing atypical hyperplasia or lobular carcinoma in situ? These people often have a 10-year risk of 0.5% to 1% per year. Or is she a really high risk, like a BRCA1 or 2 mutation carrier that have a risk of about 2% per year? Knowing what level of risk you are and knowing the short-term and the long-term implications will help a woman make decisions about what is the appropriate surveillance and what kind of prevention measures does she want to take. So for most people who are at increased risk, even moderately increased risk, the first step really is to make sure you're getting adequate screening. People that are at increased risk usually start screening with mammography a lot earlier than people who are at average risk. And they may need screening more often. They may need a twice yearly breast exam and a breast MRI added onto the yearly digital mammogram. And those are the two main things. get people motivated to start healthy behaviors, and knowing that there are an increased risk for breast cancer often does that. I've been impressed with how motivated a lot of these women are. In people who are at high or very high risk, though, they need to have a discussion about some of the standard pharmaceutical options that are open to them, as well as clinical trials. And we do a lot of prevention clinical trials here in the Cancer Center. And I have just been amazed over the years how excited and willing women are to participate in these trials, which often take a fair amount of their time, involve oftentimes getting a fine needle aspiration, but they really want to give back. They really want things to be better for their daughters and the next generation.
So we've talked a lot about risk, and I want to ask you a question just to see if your experience is the same as mine. When I'm talking to patients about risk, I always like to talk with them about their absolute risk over a defined period of time, as opposed to relative risk. And what I found is that relative risk tends to be very scary, and to overly sensitize people to the level of risk that they have. And I'm just curious if you found that same thing.
Absolutely. So in the high-risk clinic, we start with a very structured consultation. We primarily use the Tyrer-Cuzick model to calculate both a 10-year risk and a residual lifetime risk. I like this model because it gives an absolute number and it gives a relative number. So just like you were mentioning, a 30-year-old woman may have a relative risk that is tenfold higher than the average person in her age group, but she still may only have a risk of 1% or even less per year.
Right.
So you have to really inform people of both things. And you also need to inform them as to what is causing their risk, or in some cases actually a reduction in their risk. You know, what are the things that are helping to reduce the risk? For example, for many of these women, if they had their ovaries removed at 35 to 40, that could actually have provided them with a 50% or 70% reduction in their long-term risk for breast cancer if they had their ovaries removed at a very early age. Of course, it also increases their risk for heart disease.
Right.
So in those particular instances, usually you have to give them some low-dose add-back estrogen. Likewise, when they understand that living a healthy lifestyle, losing the weight, doing all that exercise 5 hours a week, minimizing alcohol can reduce their risk by up to a third, they're likely to get with the program, especially when you only put that, as you say, in absolute terms as well as relative terms.
So I'm going to take advantage of having you in the studio, and you are an icon in, I think, American medicine and in breast cancer care and research, and you've seen a lot of changes over the span of your career. Could you talk a little bit about that and kind of where you see the the future going forward?
By icon, you mean that I am old, I guess. But I'm very flattered.
No, not at all.
The biggest changes in medicine in general, I'm not necessarily talking about breast cancer, but in, let's just say, cancer treatment. I would say since the diagnosis of cancer is no longer a death sentence, And no longer do you necessarily, for most types of cancer, need to get treatment in the hospital, except for maybe the surgery part. Cancer is a much less scary thing for people, but everybody is still frightened of it. They've seen their loved ones suffer and die, either suffer from the treatment or just waste away and suffer from the cancer. So we're all still much more afraid of cancer than we are of things like diabetes or heart disease, which actually, diabetes and heart disease really kill a lot more women than breast cancer does. But in answer to your question, the good things that I've seen in medicine are the relative ease of diagnosis of many conditions, the ease of communication with other physicians, other researchers, the plethora of things we have to make our lives more comfortable when we have an illness. The flip side of all of that is, in my mind, medicine is becoming a little too much of a commercial venture. It disturbs me that we are quickly losing these small medical practices where we all feel comfortable. And I feel that patients are increasingly getting lost in the bureaucracy of commercialized medicine, and that disturbs me. I feel there's too much emphasis on making a diagnosis with a test, and not enough emphasis on listening to what the patient has to say. Many of the young physicians really don't know how to do an adequate physical exam. Almost none of them go to the pathology lab anymore to see what's going on with their patient. It's not like they don't want to, it's just that all the things that young doctors have to do today is really taking up all their time and their energy. And one of those things is we spend too much time on the computer. We spend all of our time typing. And not only does that make us thick around the middle, but that's really not what we went to medical school for. We went to medical school to see patients and to listen to patients, put our hands on patients, and help patients through both their physical issues and their psychological issues. And we can't do that if we're trying to see 30 or 40 patients a day, and then at the end of that time spend 4 hours typing up our notes. So that was a long-winded answer to your question. Again, a lot of great technological advances, but the flip side of that is access is getting harder and harder and more expensive. Doctors are just becoming more and more frenzies, more and more compartmentalized. And I hope in the future that we could come to some balance of some of those things. The technological advances, the efficiency, but still put the personalized aspects of medicine back where it was meant to be.
So what inspired you to go into oncology?
My teachers.
So Barth Hoogstraten and those
Oh,
guys?
well, he was a little later down the line. But I actually decided that somewhere around my third or fourth year of medical school that I really had to get out into the real world and away from the university for a while. So I decided to do a internal medicine residency in Wichita. It was an incredible experience. I had the best teachers, I loved every aspect of internal medicine, whether it was cardiology, infectious disease, just everything, nephrology, like surgery, like pathology. But oncology seemed to me to put all those things together, and the research aspects were wide open, and I just loved it. And there wasn't much solid tumor, as you know, oncology at that time. That was mainly done with the surgeons.
Right.
And I spent a lot of time with the surgeons, actually. So most of the oncology was actually done by hematologists. So they were treating Hodgkin's disease, lymphoma, acute leukemia, but the surgeons were mostly treating solid tumors. So I loved all the aspects of oncology, and I still do.
So when you made the conscious decision to switch more towards prevention, which at the time was a pretty radical idea, what was the reaction to the, from the higher ups, and did they just look at you like?
Oh yeah, they looked at me like I just dropped from Mars.
Yeah.
Prevention was never going to get you anywhere in terms of your career. It doesn't, as far as the practice goes, it doesn't make money. It's too hard because you have to give somebody a drug and then wait 20 years to come up with the answer, which is one of the reasons I wanted to look at biomarkers. If you change biomarkers, you deal with drugs that are already FDA approved, you don't have to wait 20 years to get an answer. But to answer your question directly, very early on I was drawn to breast cancer because it told a story, and I liked dealing with young breast cancer patients. Since I am older, there weren't very many female oncologists at the time, so people would send their young breast cancer patients to me here at KU. And we certainly just didn't have all the treatments then that we have now. And no matter how aggressive you are with the treatments, there was a fairly high proportion of these young women that had children, young children, they were in the prime of their life, had everything to live for, that died. I got to the point I just couldn't handle it anymore. And I thought, well, maybe if I was doing some research to help prevent this issue, particularly identify women who are at high risk and see because prevention treatments are coming, if we could do something about it, whether it's bilateral mastectomy, oophorectomy, drugs, something, that we could stop this horrible problem.
Right.
And I did. I didn't stop the problem, but I felt so much better doing research aimed at reducing the incidence of breast cancer at the same time I was taking care of breast cancer patients, that I think this really made me a much better doctor and emotionally able to handle whatever I had to handle. Because you know very well, most breast cancer patients, even with metastatic disease, live a very long time, 10 years even, 20 years, and they're like your family. And when you're constantly feeling like, gosh, I feel these people, because they're not in remission, they're having to undergo another round of chemotherapy or something else. You just really need something to make you feel like you're giving back, like you're trying to make it better. And I know that's a lot of what you've tried to do in your research. I know that's really important to you.
Yeah. So you have built, one of the greatest breast cancer programs in the country, if not the world. And, we see over 1,000 breast cancer patients a year here at KU, and it's a great team. The surgeons, the mammographers, the medical oncologists, the physical therapists, the plastic surgeons. What would you say you're most proud of?
The people I've helped train and the prevention center.
Mm-hmm. Thanks so much.
As well as my kids and my grandkids.
There you go. That's what's important. So we're at the close of today's episode, and those are some great takeaways, I think, from our talk. And I want to thank you, Dr. Fabian, for everything that you've done to establish the bar of excellence at this cancer center. And that's all for today. To learn more about breast cancer prevention, visit kucancercenter.org/breast cancer prevention, and join us next week at 10 a.m. for Bench to Bedside. Thanks for watching.